All right, clean freaks, welcome back to another episode of Sterile Horizons, Advancing ASC Excellence, a special Beyond Clean podcast series sponsored by Solventum. I'm your host, Bobby Parker, and in this series, our aim is to detail the unique challenges and the opportunities that come along in instrument reprocessing in the ASC setting so that you can provide the best quality of care for patients, every instrument, every time. Today's episode is all about sterility assurance, and I know what you're thinking. Come on, Bobby. Sterility assurance, it's Monday morning. I don't think I have it in me to listen to an episode about logarithmic reductions. And I hear you. But did you know that that term sterility assurance encompasses a lot more than just the calculation of log reductions, what we might think of when we open our textbook? It also has some immensely practical considerations for our departments as well. So as we dive into this topic of, how can we be sure that our instruments on the shelf are sterile, what practical matters go into that level of confidence and assurity? We're going to interview a powerhouse of sterile processing education, former HSPA president Sharon Greene Golden, and we'll be asking her about what are some of those practical things in the ASC setting that can help you sleep at night knowing that the instruments that are going to be used in tomorrow's cases are going to be sterile and safe for that patient. But before we get to that interview, we're going to take a quick break. We will be right back with Sharon Greene Golden. And joining us now in studio is Sharon Greene Golden, Director of Clinical Compliance for SIPS Healthcare Solutions. Sharon, thanks for joining the special series on ASCs. Always good talking with you. Welcome to the show today.
Thank you so much. It's a privilege and an honor to be able to share information with you today.
Well, I assure you the honor is all ours. We're excited about talking about this topic of sterility assurance, but before we dive into the content, I'd like to let people get an opportunity to know you a little better. Sharon, you've been around this industry for a little while, done a few different things. So why don't you give us a snapshot or a thumbnail of what you've been doing in sterile processing in your career and maybe why you love this industry so much?
Okay, so I am a sterile processing technician. I always like to say from the ground up. Mm-hmm. I came into sterile processing as a first level sterile processing technician. I evolved because I have the takeover spirit to becoming leadership because I wanted to see things done correctly. I joined our national association back in 1990 with my takeover spirit. Got out there and wanted to help the profession become better. I've been in the field for over 35 years. I officially retired as a manager of people February of last year, 2024. I stayed retired for 7 whole months. And then I said, this is not working for me. I've seen all the TV shows I need. And I got back into something I really love, which is compliance, which is a big part of what we do every day. I am a former president of ISHM, now HSPA. I am a minister of good helps when it comes to teaching cleaning techniques all over the world. I've done 12 missions to different parts of the world, teaching how to clean instruments because I truly believe that the one profession that does not change no matter where you are in the world is sterile processing. I have had the privilege to speak at HSPA and many other meetings. I've spoken at the World Forum. And so I am considered, due to my tenure, my longevity, and my willingness to share information, to be a subject matter expert educator.
I love that. And yeah, congrats on your retirement and your unretirement. Sterile processing is one of those things that you just can't get out of the blood. And so I suspect you're going to have a hard time putting it to bed in the future, just with how much passion you bring to your conversations, to your talks, your education, your work and missions, all those things. So I love that passion and that you're sharing it with our audience today, Sharon. So thank you and welcome. The topic of our conversation, as I mentioned a moment ago, is sterility assurance, specifically in the ASC. Now, we've been working through this special podcast series, taking a look at instrument reprocessing in the ASC environment, because there are some unique challenges there that are different maybe from the hospital. But today we want to take a look at that sterilizer documentation book, at those tests and things we run in that sterilizer, and see, is there anything unique about sterility assurance in that ASC setting? So to get us started, let's start with some definitions, as we often do. Why don't you walk us through what sterility assurance means? What kinds of things we're talking about when we say sterility assurance?
So sterility assurance doesn't change whether you're in the ASC, a hospital, a doctor's office, the veterinarian's clinic. It is actually the process that ensures that the products, for us instruments, are free from microorganisms. Plain and simple. Is it clean? Have you removed the bioburden? Have you removed anything that's detrimental to handling from the decontaminated side to the clean side so that you can work on actual sterilization? Understanding that I spoke about this, sterilization for us is all according to parameters being met. One of the parameters is that the item is clean. If the item is clean, microorganisms that are detrimental have been removed, then we know that the Bacillus stereostreptomophilus dies at 3.5 minutes if you're testing your machine. Therefore, if you've cleaned the instruments to that standard, they will be free of microorganisms that are harmful to your human being. That being said, it all still goes back to the cleaning. We don't really know, Bobby, if something is 100% sterile unless we test it.
Right. And we're not testing every instrument, right?
Right.
Mm-hmm.
If we're testing it, we can't use it. So we stand on the fact that training and adherence to aseptic techniques, monitoring, and testing allows us to say that we are within the window of sterility assurance.
Yeah, that's a helpful way to frame it. I've heard some people talk about sterility assurance in terms of sterility confidence. Like the only way we could really be sure, as you mentioned, if the instrument is sterile is if we test the instrument, but then it's not sterile anymore. You got to handle it, you got to swab it and do all those things. And so what are the list of steps we go through that give us the confidence, the assurance that this instrument has been exposed to all the processes that need to happen to make sure that the instrument is sterile? Because we can't know for sure, but we can have a high degree of confidence. And so when we talk about sterility assurance, we're looking at those processes that maybe are prone to a little bit of drift. I love that you underlined the cleaning portion of it, because that's the part that's most likely to drift. It's not that likely that when you push the sterilizer autoclave cycle button that it's going to do something wildly different just because it's second shift. But when you talk about training the second shift new technician, you may be introducing some variables into this process. Yeah. And so that's well stated.
You're right. So the number one part of our adherence to being able to have sterility confidence, and I will say it again, is in the cleaning process. You know, we spend a lot of time over in pack and prep. That's after it's been cleaned. I, after 35 years, have come to the conclusion that cleaning is the number one step. You asked me steps. Point of care cleaning is important. That's in the OR. That's asking them to please remove gross bioburden, gross blood, body fluids, so it doesn't damage the instrument. So point of care at the end of a surgical case. Once it actually gets into the decontamination area for the SPD technician to do their job is to follow, we keep saying this, instructions for use. They tell us, according to the maker of the instruments, the processes you need to go through to adhere to cleaning. And they tell you that, you've got to brush flush, you got to soak for 5 minutes or soak for 10 minutes. And Bobby, when you're dealing with a human factor, perception of time is always a problem. So getting them to know that 5 minutes is a real 5 minutes and not a 2 minutes, getting them to understand that partially cleaning is not cleaning, that you have to clean. And so teaching is paramount, because you have to literally not just let people read a book. You have to stand there and show somebody a process. This is what they meant when the IFU said soak for 5 minutes. Now, this is what it meant when they said brush. So you got to pick it up, and they said brush it under the water so that you don't splash all this and aerolize all of this bacteria back to you. So getting people to follow all of the steps. And now that we have mechanical washers for those items that can go into a washer decontaminator, we're blessed here in America because now we have an advocate, kind of, that after you've done that, you put it in the machine, and with impingement, it goes and it does its job. But it can only do what it can do. It doesn't know that you didn't really clean it.
That's right. Yep. There's no magic that happens inside of that box. Yeah.
And as you said, you push the button and it does its thing. It does allow us to have thermal disinfection for our last rinse, which technically kills any bacteria that could be left on the instrument at that point, which allows for handling on the clean side. And that's the most important thing is I'm old school, so I handle instruments barehanded. I don't put gloves on because you said you cleaned it and then you put it in the washer, decontaminator, and it according to its strip and parameters, it did its job. So I should be able to handle these instruments. And now I'm able to check the instruments for workability to be sure that they are they're in working condition, that there's no teeth missing off the towel clip, that the needle holder can really hold the needle, that there's no tissue hanging on the end, there's not a needle still attached to the needle holder, there's not a knife blade on the knife handle. This is what we get to do on the other side as we set a tray up for actual sterilization in a sterilizer.
That's right. So we've got to have it clean. As you said, you've got those standard processes. Maybe you're lucky enough with the washer disinfector to get the device clean. Once we get it to the sterilizer, though, there are some things that if you were to look up in your technician manual, sterility assurance, it's probably going to talk about some products and processes that get used in that sterilization area as well. You mentioned the spore used in the biological indicator. So why don't you walk us through what are some of those things we do at the sterilization station to make sure that all the right parameters are being met and we're getting that sterility assurance at that station as well.
Okay, so coming from an old school back in the day, when we read BIs 48 and 24 hours, we've now gotten to the point of rapid readouts. We can read a test early. The standards have always said that we needed to test the sterilizer. It would say daily, or at least weekly. So for years, we ran around and we did daily. And we tested the same cycle every day. We didn't test anything else. Testing is very important. Testing allows us to know if the parameters of sterilization have been met. So we have BIs, we have CIs, which is a chemical indicator we put into every tray, which allows the person that opens the tray to understand that a process was met. It's very important that they're able to look and see that this tray was in an actual form of sterilization, be it steam. Now we're doing hydrogen peroxide. We were doing ethylene oxide. You have to be able to prove that it was in a process. So we have BIs and CIs. We have the external tape. We have the external little buttons with dots. Everything that allows us to know that an item was in a sterilizer. Now, the parameters, time, temperature, pressure, steam, allows us to know whether or not, when we read our strip, this has been met. Did the machine get to 270? Was it at 270 for the whole 4 minutes? Now, understand, it's according to your IFU. If it's a 4-minute cycle, 10-minute cycle. I've seen extended cycles all the way to 22 minutes, Bobby. I don't understand, but 22 minutes. Did we meet that standard? Because, as I said earlier, the only way to know for 100% surety is that I'd have to take it to a lab and have it tested. So I am relying on all of these external tests, internal CIs, to let me know that the parameters, the outside rules of what it takes to meet sterilization have been met, with the caveats that it cannot meet sterilization standards if it's not clean. So I can have a strip that says the machine did everything it was supposed to do. I can dry it the right amount of time. I can put it on the shelf and store it according to the rules and regulations. But if it wasn't clean when it went in, there's no such thing as sterile dirt. That's an oxymoron. You don't have sterile and dirt in the same part of the dictionary. And even though I've had physicians that say, Miss Golden, I think it's sterile. I don't want that in my body. And you don't want to put it in another patient's body. Because, see, people have comorbidities, they're immunosuppressed, they come in with issues, and maybe it is some sterile dirt. I don't know. But when you dropped it into my belly, my body couldn't take it, and now I'm fighting for my life. So the objective is not to put anything into somebody that has not met officially sterility assurance, meaning it is free of the microorganisms, meaning that with the techniques, with the testing, with the monitoring, with the documentation of that monitoring, to go back and be able to cover yourself and say, yes, we did, that I am doing what's right for the patient. Documentation is very important because it is what allows you to see what was done. I mentioned earlier that we used to do it daily. And Bobby, what would happen is we do it on today on the second load. And unless there was an implant back in the day, we didn't know the machine wasn't really working until next Tuesday when we tested
right.
it again.
Once a week. And then if it fails, we're talking about recalling a whole week's worth of work. So yeah,
that you can't find because we don't have enough instruments in most hospitals. We've used it 5 times since then.
Yeah, well, especially in the ASC, they don't have all the spot for, storing a bunch of extra inventory. They might be turning it multiple times in the same day. So I hear you. You're spot on. We're leaning on the tests, the research, the validations that were done when that IFU was made. So we got to follow all those steps in the IFU. We got to check our parameters to make sure it meets the sterilization requirements for that IFU. And that's the promise we're making to the patient. We've followed all the steps it takes to get this thing sterile, and that's how we can have confidence. That's how we can have sterility assurance. You also mentioned technology advancing and how things maybe used to be with these longer read biologicals, with keeping track of instruments that have been tied to certain sterilization loads. We've had a lot of advances in that regard with faster read biologicals, and then also with these tracking systems that can keep track of your load documentation for you. We're barcoding trays. So, in some facilities, they're even replacing the load stamps because they've got barcodes that trace them to a particular cycle. And that can be really helpful. Maybe in an ASC environment, though, particularly if they're not tied to a hospital and they're just a standalone ambulatory surgery center, they might not have the benefit of that, fancy high dollar tracking system or even some of the newer, faster read biologicals. So I'm curious, what does best practice look like in that environment where we're still doing a lot of things with pencil and paper to make sure our documentation's right, to be able to do our load release and our recalls right, all without the use of that tracking system?
Tracking systems, Bobby, not just for ASCs, for some hospitals still, we don't have tracking systems. We're still working in the olden days, paper, pencil, write it down. And if you don't write it, you didn't do it. So, but the thing I want to put out first is that ASCs are subject to federal and state regulations, and they must focus on the safety and the quality of care for patients, period. Meaning, not having a tracking system is not an excuse for not doing the documentation that is needed. They are required, if they're taking money from CMS, Medicare, CMS, from the state, from these programs, they must follow those rules. And so to say I'm a little ASC, I'm a standalone, does not give them carte blanche to not do what's right. So the documentation of those machines and your work that you do is paramount. You must still run a BI. So you don't have a lot of money. So you're leaning on ST 79 2017, which still says daily or weekly to test your machine. But if you are in your mission statement saying that you do what's best for the patient 100%, then you have elected at this day and time, Bobby, to do every load monitoring. You want to know that every load meets the parameters of sterilization because that's the right thing to do. That means you got biologicals for every load. That means you got to document what the biological read. The technology that has come in that allows us, when we can afford it, to have readers that are attached to computers that record the results for us. Okay, but in most ASCs, they don't have it, and not necessarily, Bobby, because they don't have the money. Usually because they don't have the guidance and the understanding of how important it is to be able to say, this load met the parameters of sterilization. And a lot of ASCs are owned by physicians who haven't really studied the sterile processing side. They got MBAs now. They're doctors with MBAs. They know about the money. They know how to make the money, and they know how to do the surgery. They haven't spent a lot of time making sure that they've covered their bases for sterility assurance and the instruments that they are using, meeting the qualifications of being able to be put in a patient's body. So compliance with documentation is paramount. It's ongoing in ASCs, and the rule says they must be able to demonstrate continuous compliance, and within that shows up within their policies and the standards. So the standards do not change because you're at ASC. You still have to test your machine. If you have a pre-vet, you've got to run a dart every day. You can't say we're going to save money, we're going to run dots once a month. You have to run a dart every day. You have to test that machine at least every day. You have to have the reading to be sure that it did pass and didn't fail before you move forward. You have to test your washer, decontaminator. You have to test your ultrasonic. For years, we didn't do those things, Bobby, because we didn't know any better. But when you think about it, why wouldn't you want to know if the equipment you're using is working according to its standards before you use it? It's nothing worse than, I don't know if you've seen it, seeing a washer decontaminated with the arm missing.
Right. Yeah. It's just stuck and it doesn't spin anymore because it's all clogged up with little bits of container pieces or things like that.
And they're washing instruments, load after load, happy.
Yep.
Right? Yep. Just happy as they can be, or the arm is completely missing. You're like, wait a minute. So a lot of companies put glass doors on so that we could look and say, you know what? The top rack there's no water coming out. The arm isn't spinning. Cut the load off. Let's see what's wrong. So the documentation allows you to say, yes, I did that check. Yes, it was working. It did meet the standards. We even have a check for the heat seal about it to see if it heat sealed, if it's actually sealing correctly. So testing is important. Documentation that you did it allows you, in this country, the USA, where we like to sue, you're able to go into court and say, I did my due diligence. Here's the proof. And whether you have a computer or not, for years, we had boxes and boxes of records where we had to write down the results from all the tests. We had to check it. We had to keep the strips. We had to tape them and staple them to a paper, put them in a box, and we had to keep them just in case somebody came to ask us to prove it.
Well, I'm glad you brought up that litigation piece because it was in the back of my mind, and I want to chase it further, but I'm going to let it stand the way that you've said it, saying we got to be able to prove the work that we've done. That documentation piece is really important. I feel like the theme of our conversation today, as it should be when you're talking about sterility assurance, is that our confidence in these instruments being sterile is directly tied to how well our technicians, the people handling the instruments, are following and doing what they're supposed to be doing. Are they documenting the processes that they're doing? Are they doing the tests? Are they cleaning according to the IFU, soaking for the 5 minutes that you referenced? That's important in every circumstance. I think it is particularly challenging to get everybody on board with that kind of ownership of sterility assurance, perhaps in an ASC environment where sometimes you may only have one or two technicians working in that environment, maybe not a dedicated leader for those two technicians. They might report to the OR or something of the sort. I guess my question is, how do you create that culture of accountability and documentation and monitoring in an environment where you've just got the two technicians who've been working together since the 90s and are just, carrying on doing things the way it's always been done?
I've had to deal with the different generations in a department. People who've been there for 20, 25 years, down to people who showed up 2 weeks ago. And the one thing that you have to instill in people is that, number one, what you do matters to the patient, period. Number two, you have the right to not do what you're taught for any reason. You cannot, I want to say, take a shortcut. Shortcuts are not allowed in this field. We must follow the book and the standards. Now, when you have technicians who are working along, hopefully, ASCs, when they go to hire their technicians, number one, I would hope in the perfect world that they made sure, number one, that they had certification, which is the basic minimum knowledge for what has to be done in sterile processing. That they don't hire somebody that just has a year, 2 years experience, that they try to get experienced people who worked in a hospital. And I'm going to say that in the actual hospital setting for 2 years or more, where they had to see the bigness of what has to be done before they come to the ASC, which is a little bit smaller, where they were taught the standards of compliance of what it is they have to do, and that they have competencies, which is important. Don't bring anybody in and don't make sure they're competent to do all the jobs. It's not just, did you work in SPD, Miss Golden? Do you know how to wash an instrument? That's not good if you run in Da Vinci. You need to do a competency. See, do I know how to clean Da Vinci instruments? You need to do a competency to understand, do I know sterilization of implants? So you can't just take me at my word. I worked at the hospital for a year and I was good and my evaluations were good. That's not acceptable. You've got to be able to run them through competencies before you bring them on and say, let me see where you are. You have to have at some point somebody that has I like to use the word passion, but who has the reality that this job is important and that I must follow all the standards every day. I must document my BI. Was my control positive? Was my actual BI negative? I've got to write that down. Did I run a dart today and what were the results? I've got to make sure that's in the book. Did I test the wash and decontaminator? What were the results? All of this before I can even do any instruments. And then getting the administration of the ASC to understand the importance of what's going on in SPD. So the technician's training is important, but having the hierarchy that's running the ASC to understand what they need and why they need it, Bobby. We need equipment. So you can't put me in here with just a 3 sinks and say, go for it. Live long and prosper. That doesn't work. You're going to have to spend some money on some equipment. And some IFUs are very specific that you have to have certain. If you're doing eyes, you have to have a dedicated ultrasonic just for eye instruments. You can't put anything else in that but the eye instruments. So if you're an ASC that's doing 20, 30 cataracts a day, you got to follow that standard. But someone has to know, Bobby, what the standard is. And so either you hire technicians that know and you're willing to lean on their understanding and support them in what they tell you, or you have somebody in administration that knows, that's able to go and do the checks and the balances to say, wait a minute, are you doing what's right?
Right. And as we've talked through this series, we've even had some suggestions come out of, if you're in a small environment where you don't have that educated leader in place, budget in bringing in a consultant from time to time to take a look at the processes and be able to identify those things.
Absolutely.
So I took quite a few notes while you were giving that answer, Sharon. You mentioned a lot of things. I'm going to try to summarize real quick here. You mentioned hiring the right kind of person, somebody who's educated, but ultimately somebody who's going to be committed to do the right thing for the patient. Giving them proper education, that they can't do what they don't know. So make sure that we've got the right kind of competencies in place. You mentioned mission, talking to administration and getting people aligned on what we're going to do for the right thing for patients at this facility. And then last, you mentioned tools, like having people with the right tools to do the job. You can't comply with that ultrasonic requirement if you don't have the dedicated sonic to do it with. So I appreciate you sharing your wisdom with us there. I do think that pretty well sums it up. Hire the right folks, teach them well, get them on board with the mission, and give them the tools to do the job, and you'll see amazing things.
Yes.
Well, that's going to do it for our conversation. The time always goes so fast. I've got so many more questions that I wanted to dive into there, Sharon, but I appreciate you coming and sharing your insights, your wisdom with us about ASCs and sterility assurance today. Thank you so much.
Thank you. Thank you for allowing me to share.
Right. That was Sharon Greene Golden, Director of Clinical Compliance for SIPS Healthcare Solutions. Talking with Sharon before we recorded this episode, I was asking her about a recent mission that she went on. And if you heard in this interview today that Sharon genuinely believes that instrument reprocessing should be done the same way with the same degree of quality, no matter where it happens, whether it's in a hospital or an ASC environment. I'll tell you, she genuinely believes that and would extend that across the whole world. She wants to see that every facility is taking care of these instruments the way that they should to protect those patients who are having surgery. And so one comment from today's interview that we didn't have time to dive into, but I think is related to that topic, is when she brought up every load monitoring of biological indicators. Now, I know there are people on different sides of the argument for this one, but what Sharon said is that, the standards today say for a steam sterilizer that we need to have a biological indicator test at least weekly and preferably daily, and on any cycle that has implants sterilized on it. But she tied it back to mission. She said if the facility's mission says that we're going to provide the best quality of care for patients that we can, and if they're committed to having the same standard of care for every patient, why not have every sterilization load have a high degree of sterility assurance? Because that tool, the biological indicator, is the one that gives us the greatest degree of assurance that the sterilizer has done its job. It's the only sterility assurance method that we have that confirms live biological kill, real microbiological kill. And so I thought that was an interesting conversation, an interesting point to have. Now, whatever decision that you make about biological indicators in your facility, that is certainly a facility decision. But the underlying message from that is, let's not just meet the minimum requirements of the standards that are out there, the minimum thing that we need to do to pass an accreditation survey, but let's also consider our facility's mission, what it is that we want to accomplish for our patients, and the steps that we need to take in order to achieve that mission, even if that means elevating beyond the minimum of what's required by the standards. I thought that was an interesting conversation. I hope that you enjoyed it. This is going to do it for today's episode of Beyond Clean, the special series we're doing, Sterile Horizons, Advancing ASC Excellence. Until we talk to you again next time, on behalf of Hank, myself, and the rest of the Beyond Clean team, keep fighting dirty.